When the holidays start to feel a bit repetitive, reach for a Sprite Winter Spiced Cranberry and put your twist on tradition. A bold cranberry and winter spice flavor fusion, Sprite Winter Spiced Cranberry is a refreshing way to shake things up this sipping season. And only for a limited time. Sprite. Obey your thirst.
This episode is brought to you by Indeed. You're ready to move your business forward, but first, you need to find the right team. Start your search with Indeed Sponsored Jobs. It can help you reach qualified candidates fast, ensuring your listing is the first one they see. According to Indeed data, sponsored jobs are 90% more likely to report a hire than non-sponsored jobs. See the results for yourself. Get a $75 sponsored job credit at Indeed.com/podcast. Terms and conditions apply.
Welcome to the Dr. Raj Podcast with Dr. Raj Dasgupta, a show all about educating patients, students, and aspiring doctors about better patient care. Dr. Raj is a quadruple board-certified physician and associate professor at the University of Southern California. He was a co-host of the TNT series Chasing the Cure with Ann Curry, as well as a regular on the TV show The Doctors. And now, here's our show.
Hi, and welcome to the Dr. Raj Podcast. And once again, this is not just a podcast about how many medical pearls we can get out in 1 hour, but it's a podcast about, being yourself. It's about wellness, it's about anyone who just wants to help people. And today, the best part in the whole world about having my own podcast is I can put my friends on it as much as I want. So today I have not only a friend, I actually have a endocrinology guru. I know I'm going to embarrass him by saying that.
Wow.
But the key thing is that, I love this guy because he was actually my resident. I was so privileged to have a part in, mentoring him early in his training. And I always tell my students and residents, be better than me. And he took that to the next level. And that's why I'm so impressed with him is that, I was like quizzing this guy when he was on rounds with me. And now I'm interviewing him as the pro on these topics. So I'm so proud of him. I think the only thing he did wrong was that he didn't go into pulmonary critical care, but he could answer.
Well, had to do something different so that I wasn't showing you up too bad,
Well said and touche. But let me read a couple of things about Braden. Let's see what he gave me. So I'm going to be reading this off the list. So he completed his undergraduate studies at Stanford University. I didn't know that. So good for him. Subsequently, he completed all his medical training here at Keck School of Medicine at USC and, of course, LA County. This included med school, his internship residency, and he did his endocrinology fellowship here. And he joined full-time faculty here at Keck in 2017 after his fellowship. He is right now a clinical assistant professor, but I'm sure he's not too far away of being associate professor of medicine and a clinical educator in the division of endocrinology. And he spends his own, private practice and time teaching in clinics, teaching inpatient consult service, trainees at all levels. He loves lecturing to medical students, which doesn't surprise me. He teaches to pharmacy students, and he's been invited guest speaker on multiple topics in the realm of endocrinology, diabetes, at local conferences, CME events here in Southern California. I think he's being humble. He could have put more stuff in there. His name is Dr. Braden Barnett. Hey, welcome to the show, Braden. How you doing, bud?
Thanks for having me on, Dr. Raj. This is, I think, my first podcast. So thank you for bringing me on.
Oh, I'm glad there's another first with me here. All right, this makes it special. So, let's do the get to know each other, even though I already know you pretty well, but let's everyone else get to know you. So you went to Stanford. I mean, I'm glad you're not snooty like all the other Stanford people I know. You know what I mean? I'm glad you're down to earth. How excited were your mom and dad when you got accepted to Stanford?
They were very happy. And they supported me all along the whole process. So I owe just as much to them as I owe to, all my teachers and friends and anybody else that I, was with that on that journey along the way. I come from a Trojan heavy family. So my mom and dad both went to USC, aunts, uncles, My mom was sort of hoping I might go to SC for undergrad, but obviously they were still happy that I got into Stanford and that I went there. But then when I came to USC for my medical training, and as you read, ever since then, my family and especially my mom has been very excited since that point.
So let me ask you this. So when you went to Stanford, was your thought process out of high school, yep, I'm going to be a doctor, I'm going to be an awesome doctor? What was your major in Stanford? And was it always that medical route, or did you kind of change to shift somewhere during your undergraduate training?
It was always on the radar. I like many other people in the healthcare profession and the medical profession, especially, I have doctors and healthcare providers in the family. My father is a retired internist. My mom's an optometrist. My uncle is also an internist, occupational medicine specialist. Another uncle is an ophthalmologist. So definitely been in the family since I was growing up, but I never felt pressured by my family to specifically go into medicine or any particular field. They supported me pretty much no matter what. So when I went to Stanford, when I enrolled, it certainly was not on my to-do list of, got to be pre-med. That's going to be the goal. I ended up majoring in a program called Earth Systems at Stanford. So my degree is in Earth Systems. Earth Systems is...
what is that? I got to hear. What is Earth Systems?
I don't know. There's other programs at other schools that are similar, but this is, one of those majors, one of the programs that certain schools, in this case, Stanford, comes up with that's... kind of a mixture of, it still is, mostly a science-based major. So everybody has to take a little bit of biology, a little bit of chemistry, a little bit of physics, which, obviously did end up working out to my benefit because those were pre-med classes, but sort of, worked out in my favor, I guess, but also involves taking a little bit of geology, a little bit of economics. You have to take a computer science class. You have to take some classes involving like public policy and things like that. It's a lot of different things, or I should say it's a little bit of a lot of different things. And so I went into that sort of with the idea that maybe I might want to go into something related to marine science. Actually, I love the ocean.
Oh, all right.
Grew up close to the ocean, going to the ocean a lot. Did a lot of, like I was on an oceanography contest, like trivia team. When I was so I really liked marine science and that kind of stuff. So I went into Earth Systems. You had to choose sort of like a sub-focus within that. And my sub-focus was marine systems.
Okay.
And so that was really interesting. And I did really enjoy the major, but as time went on and when I was looking for like an internship to do between my junior and senior year, I didn't really find anything that was super exciting or thrilling to me as something to do after I graduated. And I didn't really want to pursue another degree within that field. I wasn't interested in getting like a master's degree or a PhD in marine systems or environmental science or anything like that. And so all along, I had sort of been, having the idea of going to med school in the back of my head. And I had been, doing some extracurricular things to sort of pursue that further. And it was really, just at the end of my junior year that I made the decision that I was going to apply to medical school, knowing that because it was, maybe a little bit later than some other people who know really early on that they're going to do it. And then right after undergraduate studies. Since I was a little later than them, I thought maybe there's a chance that I wouldn't get in on the first round, but I got super lucky and managed to get into med school to start right after I graduated from undergrad, which is what I wanted at the time.
Yeah.
I didn't really have anything else that I wanted to do. And I don't really regret my decision. It's not like I was going to get on a boat and be a longshoreman around the world or something. So anyway, I don't regret that decision. And then, I sort of wasn't sure whether it was the right choice right when I started med school. But within the first couple of weeks, I really felt like it was the right choice. And I felt really glad that I had done it. And yeah, no regrets.
Well, let me do a diversion question, which is, I never knew you were going to be like a Jacques Cousteau of the ocean. So have you actually been in the ocean, Braden? Like you want to do something in the ocean? Can you don a scuba gear and actually be part of that?
I'm not scuba certified, so I've never gone scuba diving. And I do think that scuba diving sounds really cool. And I know a lot of people are, they say, oh, it's, the only way to see the ocean and to see things that are beneath the surface. I've done a lot of snorkeling, and I feel like I've seen a lot of cool stuff. And I definitely look forward to doing that again in the future. And I'm not opposed to doing scuba diving, but it is, a lot of extra, or not, at least a little bit of extra time and getting all the certifications. And to be perfectly honest, freaked me out a little bit. The snorkeling, at least I know I'm always kind of in control of at any given time. So, but no, I do. I enjoy snorkeling, just going in the ocean, doing, bodyboarding and stuff like that.
Cool.
I've never surfed, even though I grew up near the ocean, but I enjoy just being around it.
So you said you went to med school, EA Trojans, you chose the right place. And, I kind of you said that you were a little hesitant at first that you made the best decision ever, but it worked out. So 2 parts of med school. Can you tell my listeners, what was the toughest part during your didactic years, the first 2? What subject did you just regret or bad memories from? And the second part of the question would be, during the 3rd and 4th year, what was the best part of med school for you where you're like, man, I am ready to, hit the floor running?
Right. So yeah, the first 2 years, as probably a lot of your listeners know, the first 2 years of med school are similar, at least in my opinion. They're very similar to undergraduate studies, except just that you are, hyper focused on certain subjects, and you're learning sort of all day long, or at least, most of the day. So instead of just a lecture that lasts for, an hour or 2, and then you're kind of on your own and you come back and you do the TA session or whatever, and you're in a group project, it's more just like, here's a bunch of information that you need to get into your skull, and you need to understand the physiology of what's going on. And so it is, in my opinion, it is just a lot of memorization. I think a lot of people would say, oh, well, you can't just memorize facts. You need to understand them. And yes, that's true. But at the end of the day, having certain things just committed to your memory that you can pull up in an instant makes it so that you're able to navigate, certain problems easier and better. So yeah, those first 2 years, just a lot of memorization, lecture. So that part doesn't, in my mind, it doesn't really require learning in much of a different way. If you already kind of have a good system for studying and how you acquire information that is given to you from either a lecture or a textbook or whatever. So what topic was the most difficult for me? I remember the neurosciences we did. So I think if I recall at USC at Keck, when I was a med student, at least that was the longest block that we did. I want to say it was like 2 months long of just neuroscience. That was tough for me. That was a lot of, doing all the neuroanatomy memories, parts of the brain and all that kind of stuff. So that one was tough. And the one I liked the most, which should not be surprising, was endocrinology, which I definitely had no affinity for endocrinology. I barely even knew what the word meant before the endocrine rotation or the endocrine block when I was a second year med student. And I really, really enjoyed that. So that kind of got my attention. And then, 3rd and 4th year. So then, that to me is sort of the more radical shift, but also sort of where things start to get a lot more interesting. So being on the clinical rotations, getting into the hospital, into the clinics, inpatient, outpatient, all that kind of stuff. So yeah, that was a big transition. And I enjoyed the first 2 years because it is kind of fun to really sort of just dive in and learn, all these topics sort of so intensely, but then sort of even takes it to another level once you're actually seeing how it works in the hospital and in actual setting. So yeah, that was, definitely there were some long days and long nights on those rotations. But as a med student, you're still relatively protected, but it's certainly an adjustment. But there wasn't any time during all of that where I thought maybe I had made the wrong decision. There were definitely times where I was maybe not super stoked on what was going on. I definitely never regretted my decision during that time.
You had to make the decision during your fourth year sometime to decide what specialty to go into as far as the broad specialties. So, you chose the best. Internal medicine is my jam. So why weren't you drawn to psychiatry? Why weren't you drawn to being a surgeon? Why don't you want to deliver babies? Some of my favorite doctors are OB-GYN doctors. Why did you choose medicine,
As I mentioned before, definitely I was probably at least partially influenced by my dad as a role model.
Okay.
He's a retired general internist. He did primary care.
Sure.
I had always seen and respected kind of the way that he described his interaction with patients, that he was sort of the one that in some way was sort of coordinating what was going on and sort of had to have a good understanding of what all the other specialties could offer. Right. So I thought that was cool. And then I tried to, again, keep an open mind when I went into medicine. Like I said, when I started undergrad, I didn't want to automatically, pigeonhole myself into going into medicine. And so just like when I started med school, I tried to keep an open mind about different subspecialties. I think that when I was doing my surgical rotations, I think surgery is incredible. The fact that you can, rip someone's body open and do something inside and then back up, and you can make them better by doing that, right? Like
or take out their pituitary in your case.
Or take out their pituitary adenoma, remove their thyroid cancer. All of those things. So, and I have, the utmost respect for our surgical colleagues. But I honestly just found that when I was in the operating room, I was just kind of like bored and waiting for the next thing.
Good. All right.
No, surgery is to a surgeon is incredibly exciting and all of that. And I'm glad that they like it. But to me, it just wasn't sort of the thing that I envisioned when I saw myself as providing care for people.
Sure.
At least the operating room part of it. I know a lot of surgeons do many things outside of the operating room too. But so that's why surgery maybe didn't grab me. A similar thing, I guess, with OBGYN, there's, procedures involved with that maybe I wasn't so excited about getting into. And I know that, there's a lot of critical thinking and medicine involved in many aspects of OBGYN as well. But, wasn't just exactly what I was looking for. Psychiatry was almost too much of just pure ethereal thinking for me. So I thought internal medicine sort of seemed like the ground where I could still, and I tried to keep an open mind even when I chose internal medicine. There are more procedure heavy specialties. There's more or less procedure heavy specialties than there's, general internal medicine, and a lot of general internists do a whole lot of different things. I ended up in endocrinology, which is probably the least procedure based or the most sort of up in the clouds sort of a specialty. But it seemed like a good balance of what I was looking for.
When my listeners, when I was interacting with Braden, it was during that time, during the residency years. And I thought we had some really good rotations together. You were always smiling. What did I do wrong to not make you go into critical care and pulmonary. You get a couple central lines here and there. There's still some thinking involved in the pulmonary. I mean, what could I have done differently or better yet, don't put me on the spot. Why did you like glucose and bone health? How did that win? Why endocrinology?
It's not you, it's me, Dr. Raj. The central line actually was probably my least favorite things to do in all of it.
Okay.
That was putting in central lines is always very nerve-wracking to me. That might have been the one thing that drove away actually the most from critical care. But I enjoyed my rotations in the medical ICU as well. And definitely I saw a lot of great outcomes for patients. Maybe the thing that was the hardest for me to see was how many, tough outcomes there are to see in the medical ICU. Yeah. That usually when a patient gets to the medical ICU, it means they're really, really sick. And even the best, most outstanding medical care we have to provide might not be enough. And that for me just, wasn't sort of what I envisioned as being my day-to-day, I guess. Right. And so I have nothing but respect for people who are sort of like, I want that challenge. I want it every day. And I can accept that, sometimes we're going to put up our best fight and the universe is just going to say, sorry, it's just, you're not going to win this one. But when I do win a challenge, like that's what I want is really to fight that fight. I think that's awesome for the Dr. Dasguptas out there and knows that. For me, I thought, well, the patients I'm going to see are people who have, true illness, true disease, and widespread disease, right? Very common, type 2 diabetes, there, osteoporosis, very common. So I'm seeing things that are real things that affect lots of people, but I guess maybe just the fact that I can have a slow but steady change on someone's outcome over several years or maybe at least several months is sort of what drew me in, I guess.
No, I love that, and now this is perfect timing. I love that you mentioned type 2 diabetes because I wanted this episode with you to be very helpful for everyone, and I think what better way than to pick your mind about disease that affects everyone, which is diabetes. So I have my questions here, and this is a treat for everyone. You're going to hear it from the horse's mouth, the specialist. So forgive me, Braden, if some of these questions are too easy for you, but can we start off with this one? Just for the general public, what is diabetes? And what are the two main types of diabetes out there?
So I go over this question with my patients on a daily basis. Someone who comes to see me for diabetes. So before I talk about what diabetes is, I usually talk quickly about how does our body usually deal with carbohydrates and glucose, sugar, right? Okay. So you got to know what's normal before you can fully really grasp what's abnormal. So I tell patients that when we consume carbohydrates, they go down into our intestines and our body absorbs them from the intestines into the bloodstream. So the first place that those carbohydrates are going to show up is in our bloodstream, and our blood sugar level is going to start to go up when that happens. When that happens, our pancreas, which is an organ located at the back of our abdomen behind our stomach, the pancreas can kind of has like a sensor in place where it can see that those glucose levels are starting to go up from the carbohydrates that we consume. And so proteins and fats, the other macronutrients, don't really affect this process as much as just carbohydrates do. So we're really only talking about carbohydrates here and foods that have substantial or significant amounts of carbohydrates. So as blood sugar levels start going up, the pancreas senses this and it releases a hormone called insulin. That hormone is a signal, it's a message. And so that signal gets put into the bloodstream and circulates everywhere in our body from our head to our toes, just like the carbohydrates are. So we've got insulin out there, we've got glucose, sugar out there. They're floating around our bloodstream, going to all these different places. And the message that the insulin sends out is it tells the cells of our body, our muscles, our heart, liver, kidneys, you name it. It tells the cells of the body, hey, there's sugar out there. And you should start taking that sugar out of the bloodstream, and you should do something with it. You should either use it for energy, or you should use it to build something. But it doesn't do our body any good to just have all this extra sugar floating around in the bloodstream. So let's pull it out and start using it for things. So this process goes on while we're digesting and absorbing more carbohydrates out of our intestines. So then our blood sugar levels sort of reach a peak or a plateau while that's happening, because as the carbohydrates are getting pulled in from the intestines, they're simultaneously also then getting pulled out into the cells of our body. Eventually, we run out of carbohydrates to absorb because we absorb all the carbohydrates that were in that meal that we just consumed. And so then the blood sugar levels start coming back down again because there's no more carbohydrates flowing in from the intestines, but there's still carbohydrates flowing out into the cells of the body due to the signal from the insulin. So then as the blood sugar levels start going down, the pancreas stops making insulin, stops sending insulin out there. So then the cells of the body stop sucking the glucose out of the bloodstream and they leave it in there. So that then the blood sugar levels will end up stabilizing and kind of going into our normal ambulatory, walking around kind of glucose levels. And we don't want those glucose levels to go down too low because
no, we don't.
one part of our body that really relies exclusively on glucose for energy, and that's our brain. So our brain does not require that signal from insulin to use glucose. Our brain just uses glucose all the time. And so that's why we don't want blood sugar levels that are too high, because it doesn't do our body any good to have a whole bunch of extra sugar in the bloodstream. But we don't want our blood sugar levels too low, because otherwise our brain shuts off and then we lose consciousness and it's no fun lying on the floor. So that's kind of how the system works normally. Type 1 diabetes. So there's two main types of diabetes in terms of, if we're trying to simplify it down to sort of easy to conceptualize points here. There's type 1 diabetes, type 2 diabetes. Type 1 diabetes occurs when something destroys the pancreas's ability to make insulin. Or in other words, the body just is not able to make enough insulin, even though the insulin it has its desired effect once it's out there. It's just the pancreas doesn't make as much insulin as it's supposed to. This is usually due to autoimmune destruction of the beta cells in the pancreas, the cells that make insulin. Although anything else that damages the pancreas could also lead to something that looks like type 1 diabetes, although most commonly it's due to this autoimmune destruction. 2 diabetes is the pancreas still makes insulin. And in fact, in most patients with type 2 diabetes, the pancreas makes lots of insulin. So the problem is not the production of insulin, but the problem is what we call insulin resistance. And so I say that this is like, imagine that the cells of the body that are supposed to be pulling that sugar out of the bloodstream, it's like they're wearing earmuffs. So they get part of the message, they hear some of it, so they take some of the glucose out, but they leave a lot of it in there and they leave too much of it in there. So the end result with type 2 diabetes is that when somebody consumes carbohydrates, that upswing on their glucose while they're digesting the carbohydrates, it goes up probably faster and also for longer. So it takes longer for that sort of plateau to get reached. So their peak is higher, and then it takes longer for their levels to come back down to sort of desired normal level after the meal, because even though the pancreas is pumping out all this insulin, its effects are sort of only part way what would be expected.
So let me ask this. Let me throw one dorky comment out there before we get to the next question. So I love that explanation. I was almost going to take notes right there. So when we're talking about the carbohydrate part of it, I can't help but think of a category of medication from med school called the alpha glucosidase inhibitors, Yes. And I guess the brand name of one of the drugs is acarbose, and that prevents you from absorbing carbohydrates. It sounds ingenious now, like, all right, the main problem is absorbing too much carbohydrates and blood sugars go up. So was that one of the first medications out there? And is it true that you only give acarbose to patients you hate?
Well, I don't really have anybody on acarbose, so I guess so, because I like everybody. But yes, acarbose is an older drug. I actually don't know the the exact date it was approved. You probably figured out real quick here, though.
Oh, look at you! You're so like technological savvy right here.
So actually, I guess the FDA approval, it says, was not as long ago as you might think. It says,
Give me the date. I'm curious.
It was approved in 1999.
I would thought like the 70s and 80s, man. That's recent.
There might have been other alpha inhibitors.
Yeah.
Well, this website says it was approved in 1995.
Yeah.
Somewhere in the 1990s.
All right.
Maybe there were other alpha glucosidase inhibitors before acarbose that we just don't use anymore.
Yeah.
But at any rate, yes, you're right. So this medication, it's not necessarily a real new medication, but yes, it works by inhibiting the breakdown of carbohydrates in the intestines, in the brush border. And so by doing that, the carbohydrates stay intact and they stay in the intestines for longer. But it does two things. Number one, the carbohydrates that do get absorbed more slowly. So then it takes longer for the carbohydrates to show up in the bloodstream. So you get a more gradual rise in the blood sugar levels after eating, which, when you imagine that the pancreas is trying to make as much insulin as it can to try and get those blood sugars down, that it's going to be easier for the pancreas to control the blood sugars if they're going up gradually as opposed to if they're going up very quickly. And then the other thing is that a lot of carbohydrates end up not getting absorbed. They end up staying in the intestinal tract.
And what happens when that happens?
Right. So then, as you mentioned, this is for your enemies. So then the carbohydrates that stay undigested in the gastrointestinal tract end up causing the main side effects of acarbose, which really sort of limit its clinical efficacy, which are increased diarrhea and increased flatulence. So why a lot of patients who start on it end up not really taking it for very long, although it ends up being effective not only for the mechanisms that we talked about, but also because some people who take acarbose end up losing weight because they have gastrointestinal side effects, and they know that the more food that they eat, the more side effects they're going to have. So a lot of people end up losing weight while they're on it, which ends up, it's not necessarily the healthiest way to lose weight, but it does lead to weight loss. And we know that being overweight and being obese, having excess adipose tissue, fat tissue in the body is a risk factor or contributes to insulin resistance. So it is an effective medication. It's just difficult for most patients to stick with. And so therefore has not really caught on as a commonly used medication.
No, and for the med students, that is the wrong answer on the board exams. but let me ask you this question. So on type 2 diabetes, and we're going to focus on that because, that's the one that we see the most in society. That's the most prevalent type of diabetes. And I guess the questions are going to be, what are the symptoms the general public should look for when you talk about diabetes? And can having poorly controlled diabetes, what are some other medical problems that can occur if we don't address this problem to begin with, which is diabetes?
Sure. So to address the first question about symptoms, one of the biggest problems with type 2 diabetes is that initially, early on, there usually are no symptoms whatsoever. So when a patient would first sort of meet our diagnostic criteria, and I'll get to where those criteria came from in a second. When a patient initially meets those criteria for the diagnosis of type 2 diabetes, most patients are completely asymptomatic. Most patients say, I never would have known, which is why screening for type 2 diabetes is so important, because people are at risk for developing complications and can benefit from treatment long before they are symptomatic. Screening for diabetes is definitely an important part of preventive medicine because most people are not going to be symptomatic.
So what are those screening guidelines? I don't even know. You're going to teach me right now. So for the general public, is it like just yearly labs, make it a fasting, or?
So it's not a 100% agreed upon answer about who and under what circumstances should people be screened for diabetes. But I think that everybody agrees that over the age of about 40 or so, at the age of 40, that anybody who is overweight or obese should get screened for diabetes. Anybody with a strong family history should get screened. So any direct blood relatives who have diabetes, anybody who has a history of maybe other diseases that could be affected by it, specifically like cardiovascular disease, or people who are of certain high-risk groups should be screened. And if your initial screen is normal, then probably rescreening every 3 years is appropriate. If your initial screen shows that you have what we call pre-diabetes, meaning you do not meet the diagnostic criteria for diabetes, you don't necessarily need drug treatment, pharmacologic treatment for diabetes, but we know that people that are in that category of pre-diabetes have an increased risk of developing diabetes later on, then those people should be rescreened about once a year, once at least. For people that are over 40 who are not obese or overweight, as I said, if they have some of those other high risk characteristics, it's certainly reasonable to screen them, at least every couple of years. And honestly, for pretty much any adult, even if they don't have any of those risk factors, I think it's certainly reasonable to screen, at least once every 3 years or so, even if their test results, their screening results are normal. For people under the age of 40, it's a little less clear, but I think still probably for people that are overweight or obese, screening, every couple of years is still probably a good idea. For women who are going to get pregnant, getting screened for diabetes before pregnancy is not necessarily universally recommended, although it's certainly reasonable. But then every woman, at least in many countries, is going to end up getting screened for gestational diabetes with an oral glucose tolerance test during their pregnancy if they don't have a pre-existing diagnosis of diabetes prior to the pregnancy.
Well, let me. People are going to be asking this question now. I feel it already. So the question's going to be: let's talk about some of these tests. But let me just make sure the listeners understand. We're talking about screening. Screening is something we do in people who have without symptoms. We call that asymptomatic. So we're talking about diagnostic testing now, which are the same tests we use for screening. But remember, once again, that's a great point that he brought up, as you probably have no symptoms in type 2 diabetes. So what are going to be, now I'm going to say 4, so I'm going to put you on the spot. So, and tell me if I'm wrong, what are the 4 screening diagnostic tests that you use to give someone the diagnosis of diabetes?
We'll start with the test that's used probably the least often, and that's the one that I brought up already, which is the oral glucose tolerance test. And so that's where you have someone come into your office, you measure their blood glucose level at baseline, you have them drink this pre-specified sugary beverage, this beverage that has a set amount of sugar in it. Measure their glucose at either 1 and or 2 or 3 hours afterwards. This is a test that is only used to screen for diabetes in certain circumstances. And the 2 circumstances that are used most commonly, the one that people are going to hear about is in pregnancy. And the other one that is probably less well known is in cystic fibrosis.
Oh, okay.
But so this is still a test that could be done in some other groups, but it's really only in those 2 groups, pregnancy and cystic fibrosis, where the oral glucose tolerance test is sort of the preferred screening test.
So are you making these patients sit in your office 2 hours after you make them chug this Mountain Dew drink, or do you send them home, or how do you get the 2-hour value?
Well, they got to stay there because you want to see the peak glucose level, the peak sugar level after consuming the sugary beverage. And so that takes up to as long as 2 or 3 hours after consuming it. So, I guess if they wanted to go home, they could, but I think most of the time people end up just staying in the office and waiting to get their blood drawn.
And that value is more than 200. Am I making up that number in 2 hours? Is that the cutoff?
For gestational diabetes, there's actually lots of different systems and cutoffs that are used, and there's not sort of one agreed upon system. So, and the numbers are sort of in the system that we use here are sort of these random cutoffs, and they're not a multiple of 10 or a multiple of 5 that's easy to remember.
Yeah.
But for non-gestational diabetes, then yes, we're looking at a cutoff of 200.
Gotcha. That's the one that jumps in my mind for some reason. So, so we got that one. What's the other one? So what's number 2?
So then just to be clear, I hardly ever order oral glucose tolerance tests. Almost never do, because I'm usually not the one who is screening someone for gestational diabetes or screening someone with CF for diabetes. I'm usually seeing them after they have been based on the screening test. So I pretty much never order oral glucose tolerance tests. So then the other test that you mentioned, the most common one that I would use is the hemoglobin A1C level.
What is it? What for the general public? What is a hemoglobin A1C?
So hemoglobin, as a quick review, these are the molecules that carry oxygen within our red blood cells around our body. And so in our blood, we've got hemoglobin and we've got sugar, among other things. But we've observed that the more sugar there is around a molecule of hemoglobin, the more likely it is that a sugar might come and attach itself to one of those hemoglobins. Now, when this happens, the hemoglobin still works. It can still carry oxygen. It can still do all of its normal
function.
Thank God. Yes, thank God. It just has a little sugar friend hanging off of it.
Okay.
And this happens, what we have found is that the sugar doesn't sort of bounce off and on and off. Once it's on there, it's on that hemoglobin molecule for the rest of the lifespan of that hemoglobin molecule until the body breaks it down into its individual components and recycles it and makes a new hemoglobin. But
that's like 120 days, right?
It's about 100, 120 days. And so that's kind of where this 3-month mark comes from, where we say, your hemoglobin A1C level correlates to roughly what is your average glucose level over the past 3 months. So this is assuming that during times when your blood sugar is high, that you're attaching more glucose molecules to your hemoglobins out there. And this assumes that when your glucose is low or normal, I guess, that you're attaching fewer glucose molecules to your hemoglobins. So that's why it sort of takes all of your highs, all of your lows, all of your averages, and smushes it all into one number and gives you a rough average.
And what is that number for? What's the memorized number here, Braden? What number says, you've now hit type 2 diabetes?
So 6.5%, which is how we measure hemoglobin A1C in this country using percent, meaning what percent of all of your hemoglobin molecules out there in your body, what percent of them are have a sugar attached to them.
Gotcha.
So we set our cutoff for diagnosing diabetes at 6.5%, 6.5%.
What about this pre-diabetes thing? Where does that fall into the number?
Pre-diabetes, the number to memorize there would be the upper limit would be at 6.5%. The lower limit would be down at 5.7%.
Okay.
So if you're between 5.7% and 6.49%, then you would fall into that category of pre-diabetes or at risk for diabetes, at increased risk for developing diabetes.
Now, if someone goes to a clinic, maybe not your clinic, is there an A1C you can stick in the finger, or does it always have to be a blood work?
No, you can get what we call point of care hemoglobin measurements. So that means that, just like you said, instead of going to the lab and drawing the blood and sending the blood to the lab and then waiting for the result to come back from the lab, you can poke someone's finger, get a couple of drops of capillary blood out of their finger, and can do a test that comes back in about 5 minutes.
Now, is that going to be as accurate as checking a glucose? Because I know many things when you do a finger stick glucose, so many things factor into it. Is the A1C more accurate when you get it from a finger stick? Or are you going to make fun of it and say, you need to go to the lab and go to the vein and repeat that?
Very good question. And I don't have any numbers or statistics in front of me that I can quote to you. But what I can tell you is that I think just like any other test that you do, if you're doing a version that's, portable, quick, fast, you have to sacrifice something, right? Those benefits. And so what you are sacrificing is accuracy. And I will say that in the past, just sort of by coincidence or serendipity or whatever you want to call it, I've had patients who got a point of care A1C done, and then either on the same day or very close when you wouldn't expect that the A1C should have changed by very much, they also got one done from a standard venous blood draw. And the values are sometimes substantially different.
Oh, man. Okay.
So, so sometimes they're not. They're usually within a couple of percentage points.
Sure. Okay.
Sometimes you'll look and, it might be enough where you would say, wow, this actually sort of changes my recommendation to this person.
Of course.
So, I think they have a role, and I think they are useful, especially if you're seeing a patient and you don't have any other blood tests that you're going to get. This is the only test that you really need to from them is just their A1C. Then I think it makes sense to do the finger stick test. And if you get a value that's clearly above your goal or clearly well at your goal, then maybe you don't need to send that patient to get another venous blood draw. But otherwise, you do kind of have to take the results you get with a grain of salt.
So let's close loop on this. Let's talk about 3 and 4. And I'm assuming we're going to talk about the main character here, glucose. So what's the last 2 ways that we're going to be diagnosing diabetes?
Another one that maybe is not used as often, but a random glucose level.
You read my mind. You
get any glucose level, any time of day, and that glucose level is over 200 milligrams per deciliter. Whether the patient has been, eating, not eating, on medications, whatever. If the glucose is over 200 and they specify in the most diagnostic criteria, like from the ADA and other societies, they say that you have to have typical symptoms of hyperglycemia. So initially we said that most of the time, or a lot of the time, especially in the early stages, diabetes is going to be asymptomatic. So the point of why they add this in there is this is to rule out the people who might just have a transient one high glucose level because they got a dose of a steroid that might cause a very temporary transient increase in their blood sugar levels that then go away later. So a random glucose level that's over 200 in somebody who has typical symptoms of hyperglycemia, which the symptoms we look for there tend to be polyuria, meaning urinating a lot, making a lot of urine, which occurs because if you chronically have blood sugar levels that are so high that you have sugar spilling over into your urine, it's dragging water into your kidney and down into your bladder along with it, then a lot of people who have chronically very high blood sugar levels end up making a lot of urine. So they urinate more. They have to drink more water to replace that urine that's going out of their body. So we call that polydipsia, when someone is thirsty all the time. They feel like they're constantly having to drink water. And then people who have chronic hyperglycemia that is not treated actually end up losing weight a lot of the time. And a lot of weight loss, it might be due to fluid losses because they're urinating so much and they're not able to keep up with the fluid losses by drinking water. Although another part of it is probably that, remember we talked about how insulin helps our body really sort of harness the energy of those carbohydrates in our bloodstream. So if your blood sugar levels get really, really high, you're losing out on all of that energy because it's all just sitting in your bloodstream, not being used.
Yeah, what a waste.
Will go into a what we call a catabolic state, meaning they have to chew up their own muscles and fat tissue just to have enough energy to keep going until they get treatment, which then can help their body actually utilize the carbohydrates for energy.
Then the last one, so we had the random, and we know its limitations. So I guess the last one, if it's not a random, would it be a fasting? Would be the last one?
You are correct. So a fasting blood sugar, fasting for at least 8 hours. So nothing to eat and nothing to drink except just plain water for at least 8 hours prior. If a fasting glucose level is 126 milligrams per deciliter or higher, then that would also meet the diagnostic criteria for diabetes. So this is assuming that somebody who has type 2 diabetes, that even if you give them 8 hours without any carbohydrate intake, that they are not able to get their glucose levels down below 126, even after 8 hours. And where these cutoffs came from, where these diagnostic criteria came from was studies where they looked at huge populations of people. And they said, okay, well, where can we actually start to see physical differences in people? Where can we actually see that somebody has a physical complication that's different from somebody who has lower blood sugar levels, right? So A1C, for example. So they said, okay, what about someone with an A1C of 5.9? Well, do they have any manifestations that are different from somebody with an A1C of 5.8 or lower? And it seemed like most of the time, no, not really. So then they just kind of kept marching up. What about 6.0, 6.1, 6.2, 6.3, 6.4? And it seemed like maybe around 6.5. And obviously this is not universal because everybody's body and everybody's sensitivity to hyperglycemia and whatnot is different. But they said that maybe around a glucose or an average glucose level, an A1C of about 6.5%, that we can actually start to see physical changes in that person's body.
Oh, wow.
Chronic hyperglycemia.
Okay.
And the first finding that most people will usually see, and so now this kind of gets to your question about what parts of the body actually get affected or by high blood sugar levels. And so the first area that we might see get damaged by chronically high blood sugar levels is the retina, which is the back of the eye. That's where light that enters our pupil, our eyeball, then goes back and sort of gets like projected on this screen that's at the back of our eyeball, and then our brain sort of interprets that signal. But the blood vessels that serve the retina, that bring nutrients and oxygen to the retina, have sort of been calibrated to work at a very specific range of glucose levels. And so glucose levels are chronically above that range, you can start to see damage to the retinal blood vessels.
Oh, wow.
And so most of the time when they were doing those studies, and they were saying, okay, where can we see that there's actually this difference between this group of people and this group of people? And they decided it was at 6.5% and higher. It was because in a lot of the studies that was where they started to see just the very, 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 very beginnings of what we call diabetic retinopathy. Wow. So diabetic changes to the retina, as opposed to people at lower A1C levels who generally are not at risk of developing retinopathy. And of course, there are some people who might have A1Cs a little bit lower than 6.5% who might develop retinopathy. There's definitely plenty of people who have A1Cs that are higher than 6.5% who may never develop retinopathy. But it seemed like that was kind of the inflection point where the risk started to become more apparent.
No, I mean, that story was amazing. And I'm excited in a dorky way because there's very few places in the body where you could look inside the body on a physical examination. Right. And this makes sense if you do a study like that, because you could examine the eye and see these changes. And let me ask you this to put you on the spot. Do you have your ophthalmoscope on you? And are you looking in the back of the eye? Now, don't lie to me. Are you looking in the back of the eye when they come in there? Or do you send them right to the optometrist and ophthalmologist right away?
I would never lie to you, Dr. Raj. And to be perfectly honest, I usually don't.
Okay.
And the reason for that is just that the ability of an ophthalmologist, or probably most ophthalmologists and optometrists are using high quality cameras and things like that to take pictures of the retina.
Yeah.
And what the retina looks like. Is just so much above anything that I could offer with my ophthalmoscope. And also it probably wouldn't change a whole lot of what I do.
Okay.
Our glycemic targets, even though, yes, they are there to help us try and prevent those complications. If I looked in someone's eye and I said, oh, you don't have any retinopathy, I wouldn't then say, oh, well, you don't need to worry about, getting your glucose under control, because I want to prevent them from ever developing retinopathy. And if I looked in someone's eye and I saw that they already had retinopathy, then I guess you could make the argument that might motivate the patient more to go out there and really do a better job of controlling their glucose. But I personally do not do my own retinal exam. I think that an eye care specialist, like an optometrist or an ophthalmologist, is going to get the best view of the retina and be able to give the best sort of assessment.
Well, I'm gonna get to these last two, but I just want to make sure I finish, because you reminded me of my statement about symptoms. So would I be wrong, Braden, to say that, in broad strokes, what organs can be affected by diabetes? I guess almost every organ in the body. And we kind of thinking about two brain types, the macrovascular complications, to make people worried about heart disease and stroke and peripheral vascular disease. And then what we're talking about is what we call like the microvasculature, like things like the eye and maybe the kidney and nerves. Is that a correct statement?
You're absolutely correct. So the complications that we have really sort of proven have a very direct relationship to the degree of hyperglycemia, of elevated blood sugar levels, are the retinopathy, which we discussed. The other microvascular complications are the kidneys, which we call diabetic nephropathy, and certain types of nerves in the body, especially the small nerves at the tips of our feet and in some cases our hands. And so we call that diabetic neuropathy. And so these large studies that have been done have shown pretty conclusively that the better you control someone's glucose, the more you reduce their risk of developing those microvascular complications. And the higher someone's glucose is, the higher their risk of developing those microvascular complications. And that has to do with damaging those very small, very delicate, very finely calibrated blood vessels that serve those organs. The macrovascular complications that you brought up, so this is really looking at cardiovascular disease, so heart attacks, strokes, and peripheral artery disease. Those also definitely are, we see them much more commonly in people who have diabetes. There's no doubt about that. And we're finding now that there are treatments for diabetes that help decrease blood sugar levels and also help decrease the risk of cardiovascular disease. Although that is a more, or I should say, a relatively newer finding, that really our data up until just the past, several years was more focused on microvascular outcomes, and we didn't have as much to talk about macrovascular outcomes.
This is a good segue. So the last two broad questions, they're broad, it's going to be talking about, I'm sure you have patients or know family members, and everyone listening today probably knows a family member has someone with diabetes. So let's say, my dad has diabetes for real and my relatives do. I can use a little exercise myself, Braden. I won't lie to you. Is there anything I can do to prevent me from developing type 2 diabetes? What can I tell the listeners?
Yeah. So, we all have room for improvement. Raj.
You always make me feel better.
You and I included. So I mentioned earlier, what are the risk factors for developing type 2 diabetes? Well, probably the biggest risk factor, the one that sort of probably has the biggest connection to the development of type 2 diabetes, is actually one that we can't change. And that's our DNA. It's in our genetics. And we know that type 2 diabetes, especially even more than type 1 diabetes, is actually tied to genetics and family history. So it's not necessarily something we can change, but it is something that we can help use to inform our own risk. So then we know that patients that are overweight and obese, patients that are carrying extra adipose tissue, extra fat tissue in their body, that they are at a higher risk of developing type 2 diabetes later on. And so what has also been shown is that losing that weight reduces the risk.
Okay.
So people that are overweight or obese, weight loss in any amount has been shown to help reduce the risk of developing type 2 diabetes. And so the two components of weight loss are dietary modifications and increased physical activity, right?
Sure.
Dietary modification. There's lots of different, things out there that I'm sure you and your listeners have heard about, including, intermittent fasting and keto diet and all those sorts of things. We definitely don't have time to go into all of those, but what I will say is that there's data to support using all kinds of different, diets and food plans and all that kind of things out there. There's not one right or wrong way out there, and different plans are good for different people. And if someone is really serious about making a weight loss plan and making a meal plan, then talking with a registered dietitian or a nutrition educator might be a really good idea. I refer almost any of my patients that are willing to do it to talk with a registered dietitian. And then physical activity. I have a lot of patients ask me, what type of exercise is best? What type of exercise should I be doing? And the answer is any type of exercise is
okay.
There's not, good exercise or bad exercise. Anything that gets the heart going, kind of gets people burning calories and breaking a sweat. Those are all going to be good. Those are all going to burn calories. Those are all going to increase your metabolism. So all of those are good things to do. And then in terms of other things besides just diet and exercise and weight loss, we know that smoking also, even though it might not increase the risk of type 2 diabetes itself very much, but it definitely increases the risk of complications from diabetes. So as a pulmonologist, I'm sure this is a topic that you're very passionate about, but quitting smoking, or at least reducing the amount of smoking, or for people who already smoke, and avoiding starting smoking for people who don't. And alcohol consumption probably also doesn't help. Although, that's a whole nother talk that I'm sure you could do, is, the pluses and minuses of, moderate alcohol consumption. Is it really protective or not? But certainly we know that alcohol abuse, drinking in excess, probably does not help with either the development of diabetes or preventing its complications.
Now, let me ask you this. More of a question than a statement. So would you say, Braden, for myself, would a good first step for me be taking the Sour Patch Kids I have next to my bed in my little drawer that's hidden? Should I remove those? Would that be a good first step?
Good question. Carbohydrate restriction. Right? So the natural assumption is what you just said, that if we get rid of the Sour Patch Kid, get rid of the sugar, you then no diabetes, right? And it probably is true that restricting carbohydrate intake, and definitely restricting, the simple sugars, right? The stuff that we really know has no, I'm sorry to say, Dr. Raj, that has no nutritional value, like your bedside stash.
I'm gonna edit this part out because I want. I'm just joking.
You don't want to live in a world where you can't enjoy that. But yeah, so probably those do help. Although honestly, when they've studied, does a low carb diet necessarily prevent diabetes? And sort of mixed results in some ways, but certainly it seems like it doesn't hurt. And yes, definitely, there's kind of two different carbohydrates that we can talk about. We can talk about simple carbohydrates and complex carbohydrates. And simple carbohydrates, especially things like candy, pastries, things that are really, really sweet, which, hey, I eat them too, but definitely those do not really have any sort of nutritionally vindicating value, unfortunately, and probably do cause you to have increases in your glucose. Do they actually increase your risk of diabetes? If they cause you to gain weight, if they make it harder for you to lose weight, if you're overweight or obese, then probably yes. But, eaten in moderation probably don't have too much of a bad effect. And then the complex carbohydrates, things made from whole wheat, whole grain types of carbohydrates like that, those are probably not going to be a huge contributor, although there's mounting evidence that certainly moderating your intake of those is probably a good idea as well.
Man, I love how you took my jovial statement to like this awesome scientific answer. Oh my God. But maybe I'm teaching you something here, but I also do sleep medicine. And one of the things that there has been scientific association is sleep apnea, and that's one where my team and your team of endocrinologists kind of team up a little bit. And it's more like chicken and the egg. You know what I mean? Yeah. Right. Poorly controlled diabetes, type 2, you're obese, you got sleep apnea. Is the sleep apnea making it worse? So can I put that on your list of risk factors if you think you have sleep apnea?
Absolutely.
And get evaluated for both, you know what I mean?
For sure. Absolutely. No, it fits in with the whole, sleep apnea is definitely part of the whole picture of, metabolic issues that all kind of go with this same topic that we're talking about. I completely agree.
Cool. And, for the last one, I got to tell you, it's amazing how fast the time went. I mean, I got some really super dork questions, but I think we're going to save the real in-depth for my part 2 with you down the line, because I assume you had a good time, right? You're having a good time?
Great time.
All right. So let's finish on this. I got to tell you something about treatment. I just have to. It wouldn't be a closed circle. So let's say someone gets diagnosed with type 2 diabetes. We'll keep it simple because we could go far away. I'm sure the number one question people ask you is, hey, Dr. Braden, you diagnosed me with type 2 diabetes. Am I going to have to go on insulin? How do you address that? And then after that, I'll give you my last question is going to be in regards to oral meds, what would be your go-to? But can you address the insulin question first, and then we'll call it a day?
So insulin is, probably the oldest medication that we use to treat diabetes of either type. And I actually think
I love that you're doing this live. This is great.
Yes, well, I wanted to make sure that that yes, this is the 100-year anniversary of the discovery of insulin by Banting and Best at the University of Toronto in 1921. We've known about it for 100 years and started using it in, I think, the year after, in 1922, they tried using it for the first time. So for patients with type 1 diabetes, unfortunately, their only treatment option really is insulin. There are these other treatments that have been added on top of insulin that can be tried in patients with type 1 diabetes, although none of them are really technically FDA approved. But insulin is an absolute must for every patient with type 1 diabetes, at least for the current time being. For patients with type 2 diabetes, I think we probably used to have more patients on insulin than we do now because we just didn't have as many treatment options. But insulin is really not an ideal treatment for many patients with type 2 diabetes.
Okay.
There are some patients with type 2 diabetes who are well served by insulin, but for some other patients with type 2 diabetes, insulin may not be an ideal treatment for a couple of reasons. One is that obviously insulin is an injection, which is less convenient than something that's not an injection. Insulin, at least in this country, is quite expensive, actually.
Okay.
Again, is a whole nother
podcast.
I'm not necessarily a great resource on that topic, but what I can tell you is that yes, insulin is in this country not cheap. It's actually relatively expensive. Insulin has the potential to over-treat patients and cause hypoglycemia. So remember about how when the pancreas sees that blood sugar is going down after we reach our peak, our plateau, and it starts coming down, then the pancreas turns the insulin off. Well, if you inject someone with insulin into their skin, that insulin is going to get absorbed no matter what you do and no matter what's going on with your blood sugar. That little ball of insulin that's getting absorbed after an injection doesn't know what your glucose is. And so that's why people who use insulin injections run the risk of developing low blood sugars or hypoglycemia. And then finally, the use of insulin in a lot of people leads to weight gain. And the reason for that is, as we were talking about earlier, when you've got all this sugar, all these carbohydrates that are sitting in your bloodstream, and they're not being used for energy or to build things, that a lot of people end up losing weight if their blood sugars get high enough. If you put them on insulin, now their body is harnessing all of that energy. They're drawing all of those carbohydrates out of the bloodstream. So then they might start taking those carbohydrates and turning them into fat cells. So that's one source of weight gain. And then also probably they're going to stop urinating as much as they were before. So then they're going to start holding on to more fluid, and they might gain some fluid weight as well. So it's sort of this cruel cycle that patients get put into, where their doctor's telling them, you've got to lose weight, you got to work on losing weight. And then we put them on insulin and they gain weight because of the insulin. So it's not an ideal treatment. Although, to be clear, if there's people out there whose doctor, who they have type 2 diabetes and their doctor put them on insulin, your doctor may have a good reason for putting you on insulin. And there certainly are patients with type 2 diabetes who need to be on insulin or who are best suited for insulin therapy. But I think that the movement and sort of the goal is to try and avoid using insulin in patients with type 2 diabetes. Possible. And so that's why there are newer medications that are coming out, that have come out over the past 15, 20 years, and new medications that will continue to come out in the next 15 and 20 years that are hopefully going to make insulin less and less relevant for patients with type 2 diabetes and hopefully make it so we have other options that don't predispose people to low blood sugars, don't cause weight gain, and don't have the other sort of undesirable consequences of insulin therapy.
Well, this is, once again, great setup for my final question. I was going to give you the broader thing, which I think is going to be our next podcast together with you, which would be, we could do an hour on just treatment itself. But if you had to pick, now I'm assuming me and you are always on the same wavelength and we think the same. So don't let me down here. Okay. So if you had a type 2 diabetic who had, good kidney function, everything's doing fine and a little bit on the overweight side, and you had to pick one drug, just one drug of the variety out there, that would probably be the most best first initial treatment orally for a type 2 diabetic, what would you pick? Because I'm already thinking of one that I want you to talk about, but I'm a little scared here. What would you offer?
Everybody's answer, or almost everybody's answer, is going to be metformin.
Yes.
And that's my answer.
Can you talk about metformin, too? Is that the right answer first off, or is that the wrong answer?
In my mind, it still remains the right answer.
Oh, thank God. Okay.
I mean, there might be people out there who disagree, but I think all of the societies and medical groups out there that make recommendations on the treatment of type 2 diabetes, I think there is still consensus that metformin remains one treatment. Metformin is an orally administered medication. A tablet that helps reduce insulin resistance. It helps reduce what we call gluconeogenesis, or that's the sort of synthesis and secretion of glucose from other raw ingredients from the liver, which our body does when it is only really supposed to do when we are sort of running low on glucose and we need sort of an emergency supply. But often in patients with type 2 diabetes, their glucose kind of gets their liver gets mixed signals and kind of starts doing that on its own. But so metformin remains our number one first line treatment for diabetes for a couple of different reasons. One is that it's administered orally instead of an injection. And so that's easier for people to get started with. Number two, metformin does not cause hypoglycemia, low blood sugar.
That's huge, right?
Yeah. So metformin can take patients who have high blood sugars and can help bring them down into sort of our goal range. But metformin by itself does not cause hypoglycemia. Basically, you can think of it as, if somebody who has normal blood sugar levels takes metformin, that the mechanism by which metformin works sort of can't complete the circuit if the patient's not hyperglycemic. There might be other benefits to people taking metformin who have normal blood sugar levels. Again, a whole nother podcast. but for people with diabetes, the idea is that if you have a high blood sugar level, it's going to help, bring it down and hopefully keep it there, but it's not going to drop the blood sugar levels down too low. It does not cause weight gain. And in fact, a lot of people who take metformin lose a little bit of weight, which might be part of the reason why it works. It's not really a weight loss medication. So it's, if you look at the indications or the reasons why metformin is approved for use by the FDA, weight loss is not one of them, although it does do that for many people. And metformin has been around for quite a while, and medications like metformin. So it's generic, it's cheap, easy to get, widely used. We have a lot of experience with it, so we know that it's safe, or at least we know under what circumstances it's definitely safe and what circumstances it's not safe. So lots of experience on its side. So yes, that's why metformin remains the number one go-to first-line medication for people with type 2 diabetes who require medical pharmacologic treatment.
You're the man. I got to tell you, number one, we could have gone even longer. Number two, that was one of the best answers for everything I was asking you. You're the best. So let me do a little closure and let me ask you a couple of questions. So everyone out there, this is Dr. Braden Barnett, the most amazing endocrinologist in the whole world. Yeah, I mean it. He wrote for many of my books for my Beyond the Pearl series. So if you want to see his written work, Braden, I'm just going to make it awkward and say you're going to be my endocrinologist for my podcast. Is that going to be okay?
Sure. Yeah.
I mean, you're just amazing. And I think we're going to have to get you back here and focus on some more diabetes things, and maybe we'll do some bone health. And I'm sure many people have thyroid questions. So you're going to be back. Okay.
I'll be back.
Did you have hey, I like the little Terminator thing at the end. Thanks for coming today. I really appreciate it. And trust me, we'll talk soon.
Sounds good.
Thanks for listening. This has been a production of Ars Longa Media. Our producers are Madison Linden and Chris Brightigan. Our executive producer is Dr. Patrick Beeman. This podcast is for educational purposes only and not intended for medical advice. Ars Longa, Vita Brevis.
So you want to start a business. You might think you need a team of people and fancy tech skills, but you don't. You just need GoDaddy Aero. I'm Walton Goggins, and as an actor, I'm an expert in looking like I know what I'm doing. GoDaddy Aero uses AI to create everything you need to grow a business. It'll make you a unique logo. It'll create a custom website. It'll write social posts for you and even set you up with a social media calendar. Get started at GoDaddy.com/Aero. That's GoDaddy.com/AIRO.